Hi, this is Dr. Krishna Deepak, and welcome to another episode of Sip, short for Stethoscope and Sip. And this is a unique podcast where I interview doctors, I myself being a doctor, and this is for the benefit of other doctors. And today we have a very famous and a very important doctor all the way from Odisha, that is Dr. Sukanto Kishore Das. He's a nephrologist, he's also a writer, he's also a YouTuber. And without any further delay, let us invite Dr. Sukanto Kishore Das to our studio and let us ask him about his journey in the field of nephrology. Sir, welcome to the podcast.
Thank you. Thank you for inviting me to this important podcast.
Sir, it gives me immense joy to sit in front of you because I heard that you're an author, and I don't think so. There are any doctors who have had the acumen or the thought to write a book during COVID 19. So you have written a book during the COVID 19 pandemic. I mean, at the time, what was your experiences and everything? And I think I have the book with me, A Disturbed World by Dr. Sukanto Das, and you can see, and he gives a lot of perspectives, not only from a medical point of view, but also from a geopolitical point of view. It is a very interesting read. I hope you all go through it. So, what made you come into the field of nephrology? I mean, just give a brief about yourself. Where are you from? Where did you do your MBBS from, MD, and what made you come into DM nephrology?
Yeah, first of all, thank you for reminding me and my interest in writing about books. And of course, we'll come to that later on. Now, as just you asked me about myself and my journey towards becoming a nephrologist. Look, I'm from Odisha and I was practicing in Bhubaneswar. I did my MBBS from MKCG Medical College, Parampur, which is one of the oldest medical colleges in the state of Odisha. Then, of course, after completing my MBBS, I went all the way to Lucknow to King George Medical University, where I pursued my MD in general medicine, and it was very surreal experience. And that was the time when I developed a keen interest in the field of medicine at first, and I also managed to get a gold medal. The life was so hard, and it was so much of a learning experience out there, and it was that experience, that work in medicine in KGMC, which prompted me. And there were a lot of nephrology related patients, and at those days there were not many nephrologists around. And I mean, 10, 12 years back or 15 years back, it was still a niche subject, and that incited me, and I worked hard. Of course, I got into SGPGI, which of course you can say is the pinnacle
Yes.
institute, as the center of nephrology, where I trained as a nephrologist. Another part was also my elder brother was a urologist, and
Oh.
he also kind of inspired me
Hmm.
to set my journey towards becoming a nephrologist. And after that, of course, I completed my DM and came back to my state, Orissa, to practice here as a nephrologist.
Wonderful. So, you're a sports fan?
Yeah, I'm a sports fan. I
Wow.
do play badminton off and on, but don't get a lot of time. I would
Okay.
love to if I get more time to
Okay.
that.
Let me throw a cricket term at you, a googly right
Yeah,
now.
sure.
It will be like a googly question. So nowadays, it would be this question would be your answer would be like a direction to the new coming postgraduates or who want to pursue DM nephrology.
Yeah.
Can you tell me five things for which you should pursue DM nephrology, or five things which are not so great in DM nephrology, pursuing DM nephrology?
See, I mean, it's a very interesting question, as truly a googly. Not just DM, nephrology. I think any person who has to pursue a DM in any subject, and if we can I mean, pinpoint towards nephrology, why one should do it. First of all, it gives you an immense satisfaction in handling a kind of patients, a population of patients who really need life-changing decisions. As a nephrologist, you mostly deal with critically ill patients, patients suffering from end-stage kidney disease, who need dialysis. But before that, if you can intervene at the right time to delay chronic kidney disease so that patients do not end up into end stage kidney disease. So one first thing is that your approach towards the patients and the ability to make critical decision and changing the life of the patient. Second is giving them a new lease of life with transplantation. And transplantation is coming up like anything. And in our country and in also in our state of Orissa, it has remarkably grown. And of course, your satisfaction of after pursuing MBBS and MD, if you're getting into a super specialization branch of DM, so it's nothing like it. Why one should not do it?
Mhm.
Look, medicine
Or
has.
who are the people who's, I mean, this kind of psychology or this kind of mindset, this would not be a right thing or something
See,
like that? What are the five things
yeah.
you feel that, no, take another branch or don't come into this branch, or it
See,
wouldn't be very, very well suited?
yeah, you're very right. It's very, very tough. It's highly demanding. It needs a lot of time, lot of involvement, and you're on duty, on call 24 into 7.
Yes.
So if you're an easygoing guy who wants to relax, then nephrology is not for you. It needs constant touch with your patients, constantly learning, continuously educating yourself and updating yourself. And mostly you deal with patients who are often terminally ill, so it can have an emotional impact on you. No doubt you have to keep your head together to give them that lease of life. You have to be balanced. So if you think medicine is for fun, if you think medicine is for giving you a lot of financial advantage, then nephrology is no more financially very lucrative. But again, that should not be the goal. You can just make a decent living, and of course you will have a lot of satisfaction as far as so
Yes.
that is where you should do. And if you really want a lots of fun and easy going, maybe it's not the right thing.
Yeah, one thing what you said, actually, I think it's going to stick with me for a long time, is why you should take nephrology. That is because you have the ability to decrease the progression of the disease,
Yes,
to slow down the
absolutely.
progression of the disease. The decisions you take very early on, and the counseling of the patient, how you do it, that will actually make a difference in slowing down the progression of the disease.
Yes, yes,
And
absolutely.
you can, I mean, dialysis is a very bad word in nephrology. So you can, with your, when the patient comes to you very early on, with good form of counseling, expert care, and taking timely decisions, you can slowly progress the disease.
Yes.
So that's an important thing. So you actually practice transplant medicine.
Yes, yes.
So, how is the scenario in Odisha? Do you have any program in Odisha for transplants? Like where I come from in Telangana, we have Jivan Dan program. Do you have something similar here?
We don't have such a name, but we have a very robust transplant program in the state of Orissa. And
Is it
back,
government
I'll come to that.
regulated?
Like, first of all, government doesn't have a separate program for transplant, but the Ayushman Bharat Yojana, which
Hmm.
provides financial aid to patients for the treatment, continues in its form as GJY. In Earlier it was BSKY. A state funded program is there which
Hmm.
provides financial aid to patients for their transplantation. This is for both live and cadaveric transplantation. The program you're talking about in Telangana probably is basically a cadaver transplantation
It
program.
is a cadaver transplantation or brain dead people organ
Yes.
donors program where you have a centralized database. There is a committee
Yes, we
and
have.
matching happens.
We have.
So,
We
so
have a centralized database in Odisha, which SOTO,
okay.
which coordinates with NOTO. And we
Mm.
also have a centralized database, and cadaver transplants have picked up in the state of Orissa. There's so many medical colleges, so many
Mhm.
corporate hospitals are into transplantation of cadaveric transplantation. And life transplantation, of course, has picked up like anything. And in 2010, when I came to the state of Orissa, transplantation was when bits and pieces. So we got a chance to increase the scope of transplantation, delivering more and more successful transplantations as far as the medical literature is concerned. And changing, making a paradigm shift in the overall transplant scenario in the state of Orissa, so that nowadays I can happily say that people from neighboring states are also coming to us with the hope of getting transplantation, and they're going back with satisfaction. So it's all the more important.
So
As you
you're
said,
getting patients from other states also getting transplanted in Odisha.
yeah, of course, they do
Okay,
get.
and it is from, forgive my question, because I have some of ulterior motive in this. So the in the patients that you're seeing who are coming outside of Orissa, is it from a little less developed states, or is it from highly developed states like from?
I wouldn't comment on that. People do come from neighboring states. Sometimes states, like many of the patients from southern part of Orissa go to Andhra Pradesh
Yeah,
because
that's
it's
true.
nearer to them. So it's a geographical people
Uh,
for coming from states like Chhattisgarh, Jharkhand, from those parts which are bordering Orissa, and in some states, of course, maybe overall development is a different issue. Maybe the transplant scenario has not picked up.
Why I ask this
So
question is because if you say that patients from developed states with a very high, robust hospital infrastructure are coming to Odisha,
no, not really.
then
Yeah.
I feel that maybe the cost is down in
Yeah,
Odisha.
sometimes it's costed more or less similar all over India. Maybe Odisha overall healthcare cost is much less compared to other parts where the costs are anything skyrocketing. So its costs are very reasonable here.
Okay. So that is also one thing I wanted to find out whether if people are, see, we
And
have
sometimes they get inspired, they get word of mouth that
word
this
of
and
mouth.
this patient has, many patients from Odisha who are staying in those states, working there, have done their transplant over here, gone there, they're living
Yeah,
a
yeah.
good life. So
They are good
maybe, yeah,
ambassadors for
they
your.
may be good ambassadors.
So why I say this is because we get patients from US, UK. There
Yeah,
is a
in
lot of
fact,
medical
I
tourism. So is
do.
there some kind of domestic medical tourism going on in our
We
country?
have patients from United States, Odia people who are non-resident Indians. Obviously, they got into end-stage kidney disease in United States, and they have to go start initial dialysis and there and plan for transplantation. They came back, they have done their transplant. We have a patient from Middle East also. He also underwent transplantation. They are thankfully after transplantation they are back in their life. They have gone
Wonderful.
back. One patient is in UK also. So I mean, it gives you an opportunity to serve a diverse array of people from different parts of the
I
world.
understand. So my next question is more of my doubt. Uh, we have transplantation. What is new in transplantation? And my basic understanding, what is new in transplantation, is less to do with technique and more to do with your immune suppression and these kind of techniques. So, can you just throw a light on what is new in transplantation? How was transplantation different when you started nephrology practice? Today, what are the things that you're doing different, and what are the new things which are coming up in the future for transplantation?
See, as far as immunosuppressive regimen is concerned, we do not really have too many new things in transplantation. But yes, of course, we have become more proactive in identifying which cases can develop graft dysfunction at an early stage, so that we can go for a protocol biopsy or a biopsy as and when required with a threshold of with minimal graft dysfunction, and we can intervene at the right time. And that apart, regular follow and regular uses of medication, all those things, compliance, what I would say, has really changed the overall outcome as far as the overall life of transplant patient is concerned.
Okay. So, when you started practice and now, there is not a drastic difference in the
No,
way
as far
things
as
are done.
immunosuppressive, there are a lot of things have come up in the field of immunosuppressive treatments, but the basic structure of a post-transplantation immunosuppression regimen, the three-drug regimen, where we have a, calcineurin inhibitor like tacrolimus or cyclosporin,
Tacrolimus.
or we have a mycophenolate mofetil or azathioprine, and of course steroids. These three drugs remain the mainstay of transplantation. We have different induction regimens like ATG, grafalon, and basiliximab. As and when required, you use
Okay.
those.
ATG was actually, I was about to ask you that. You mentioned antithymocyte globulin. What is its role, and how frequently do you use it in graft versus host reactions in transplantation?
In our spectrum, it would be more of graft rejection, because in kidney
Rejection.
transplantation, we do not see so much of graft versus host rejection. That's more often seen in patients of stem cell transplantation and
Okay.
other organ transplantation. ATG, we use in two first of all, induction. It is a mainstay of induction, where ideally one should use, and what we use is, of course, if a patient has a positive cross match, or if a patient has a high chances of rejection going for second kidney transplantation, or he has got multiple pregnancies, or a past transplantation where there has been a rejection. So all those things mandate an ATG induction. And of course, ATG or thymoglobulin is also a mainstay of treatment of resection if it is a predominantly cellular resection. Sometimes, even if it's a mixed resection with antibody mediated resection, ATG along with plasmapheresis and IVIG is also a mainstay of treatment.
Because this, I think, will pick up more. Why? Because recently Nobel Prize was given to in medicine, was given through three people, and
Eminent.
one of them was they have discovered a new type of T regulator cells. Previously, it was thought that thymus was the one which was priming all the lymphocytes, but now it is said that there is a different kind of lymphocytes which is actually regulating autoimmunity. So that is a big field now. So that is good. So in Odisha, a state where you practice and you do extensive nephrology and transplant practice here, what is the usual wait time for a new kidney here? I mean, let us say cadaver kidney. Let us not talk about what you call relatives donor, live donor kidneys. Cadaver donor, what is
See,
the
we do
usual?
not have a large number of patients in the cadaver waiting list database, but
Hmm.
whatever number of patients we have, the number of cadaveric donors coming up is also few and far between. We don't have more than 2 to 3. I mean, it's hardly within 2 to 3 a month, or even less than that. So a little longer. Cadaver transplant waiting list a little longer. Majority of patients still go for life related
Live
or
relative.
life transplants.
That makes sense. Wonderful. Another thing which I wanted to ask you is not a very recent, what you call a technique, but a technique that has shown a lot of advantages. That is hemodiafiltration. So, do you do hemodiafiltration in your practice, or what do you? Can you share some lights into this process of dialysis, which gives a lot of added advantages in long-term complications of dialysis patients?
See, hemodiafiltration, we have had dialysis for a long time. It's just one step ahead of that. We give certain amount of fluids during hemodiafiltration, and the machines are a little different, and it gives a better compliance of dialysis over of quality dialysis. In very simple terms, what I can say is that like those patients who cannot go for transplantation, they have to remain on dialysis for a long period of time.
True.
So what's our job and what's our responsibility is to provide them the best possible dialysis, and people have survived on dialysis for more than 10-15 years. So if with hemodiafiltration, with the same or similar machine, we can give them a better dose of dialysis, a better
Long-term.
adequacy of dialysis is better, then of course their uremic toxins will be cleared in a better way. Their metabolic profile will be better, their hemodynamic profile will be better, blood pressure will be better controlled, and also with hemodiafiltration, many times the hematological parameters are also well maintained,
Okay.
and the dialysis, the side effects during dialysis are also a little less. So, with all that, hemodialysis is one step ahead, which ensures that a patient gets better quality of dialysis. For a general public, I can only say this much about
Wonderful, wonderful.
hemodiafiltration.
See, your practice, I think it's more than a decade long practice that you
Yeah,
are
of
having.
course.
So, what are the new medications which have come? In our country, most of the CKD patients, I'm a physician myself, most of them are usually hypertensive or diabetic or, IgA nephropathy. So, what are the new medications which come to your mind, first come to your mind when you say they have made a difference in nephrology practice and giving mortality and morbidity benefits? What is one or two drugs that you feel have actually changed the game a lot?
See, since you're a physician, last few days we are talking a lot about a certain group of medications, or two to three groups of medications which have made a significant difference and hold a lot of promise in coming future. One, of course, is SGLT2 inhibitors.
Mm-hmm.
SGLT2 inhibitors have a significant promise and have been proven by various studies. We had the latest one study is EMPA-KIDNEY trial, and that study
That is
also
for
has
empagliflozin.
yes, empagliflozin. Earlier we have DAPA CKD, lots of trials which have clearly shown that dapagliflozin or empagliflozin, they can be given. First they have started with for patients of heart failure,
Yeah.
then subsequently they were given for patients of diabetes,
In fact, I
then
remember that when canagliflozin, dapagliflozin came, CKD was actually a kind of a contraindication.
absolutely, yeah.
They said no, don't give it because the manner in which it works is sodium glucose
Yes,
transport
yes, SGLT2
with
inhibition. So that it might have, but it was in retrospect found out that it's beneficial for chronic kidney disease in patients with diabetes. And there was one step ahead. It was found out that these patients who do not have diabetes and chronic kidney disease, there also it can delay the prognosis or progression of CKD. And the impact kidney also showed us that the drug can be used when the GFR is as low as 20. So
20.
even at a fairly advanced stage of chronic kidney disease, we can use these drugs. That's so SGLT2 inhibitors is the first group of drugs. Second is finerenone antagonists,
Okay.
finerenone or non-steroidal receptor antagonists,
Okay.
finerenone.
Okay.
Now, finerenone, we have always been familiar with steroidal antagonists, mineralocorticoid receptor antagonists, but non-steroidal mineralocorticoid receptor antagonists like finerenone, they can delay the progress of chronic kidney disease without causing significant hyperkalemia.
Okay.
And the third one is, of course, GLP-1 receptor agonists, which, of course, of late we are talking a lot about
Weight
their
loss.
weight loss regimen. But apart from that, they do have a significant metabolic profile in reducing the overall progression of non-alcoholic steatohepatitis or all the metabolic diseases and metabolic syndrome that can predispose to chronic kidney disease. Because in India, all over the world, we have diabetes, hypertension are the leading causes of chronic kidney disease.
True.
So these are the three important drugs I think who hold a lot of promise, and we all practice evidence medicine,
This is
evidence-based
important
medicine.
information for especially people like me, physicians or GPs, because I was hesitant in writing SGLT2 inhibitors when I see a CKD case. But this is a great learning because
Yeah.
nowadays, whenever I'm seeing some prescriptions of nephrologists, I'm seeing this empagliflozin. It's like, why are they writing this? It was previously contraindicated. Has something new come up? And now, as you rightly said, that this is making a great difference. Good. So, see, you're a nephrologist par excellence, and what is the advice that you give to Indian population 35? Uh, Previously, when we used to, I mean, when I was in my medicine, it was like 40. Above 40, you start getting, you have to take your risk factors very seriously. You need to get general health checkup, and you have to look for proteinuria or microalbuminuria, things like that. So now I think because of our lifestyles and everything, the age has come down. We are seeing, as you know, and as many of our audience will know, even general public knows, we see a lot of heart attacks or MIs
Yes.
in even gyms. Young people with good physique,
Physic otherwise.
they are getting maybe some VT. I wouldn't say it is a heart attack. Some ventricular
Yeah, it's
tachyarrhythmia
very
leading to death.
unfortunate, but it's happening.
So, what would your advice be for general population? What are the steps in health-wise or kidney-wise they have to take? What kind of foods to avoid, or what kind of what pills to avoid? What, in a general, maybe 5 minutes, if you can summarize your more than 10 years of
Yeah, of
experience.
course. That will be a very important point to make. And what I can say in general for most people, as you just pointed out, that as the incidence of early heart attacks in a younger age population is very very frightening. People otherwise healthy, no previous or known history of any kind of chronic disease, suddenly falling off in a gym or on a stage or in a sports court, and there's all frightening. So that indicates that no age is immune to such kind of diseases or such kind of attacks, because cardiac diseases and chronic kidney disease, it's a continuous spectrum, cardiorenal kind of spectrum.
Yes,
So
true.
and fortunately the disease or the presentations can be frightening, but the prevention is simple and very easy. What we have to remember is that in India, diabetes is the predominant case of chronic kidney disease. Hypertension is the second leading cause. Diabetes is 60 to 70%, hypertension 20 to 30%. And in some cases, we also have unknown kidney disease, people who
Yes.
have chronic kidney disease of unknown origin. So people have to do, if they have a family history of chronic kidney disease, they have to be aware that they have to measure their blood pressure, their blood sugar, if they have in their 30s, and go for not very frequent but yearly once or twice their checkup with simple urine examination, that many times even as physicians we do not advise, is so important. If protein is diagnosed in urine, that's one of the earliest markers that can change
True.
the overall spectrum of the disease. That's number one. Number two, as you said, lifestyle modification. Of course, we depend so much on nowadays. We order and food is delivered at our doorstep within 10 minutes, but that food comes along with a lot of risks. Simple home cooked food with home ingredients is still the best. Indian food and Indian traditional food still has the best benefits. It doesn't have too many additives, too many risky factors. Third thing, of course, over the counter pills such as painkillers and all those things have to be avoided. As I just told about processed food contains a lot of salt. So we have to reduce the salt intake. The oil intake has to be less. And protein intake, animal protein intake has to be reduced, because animal protein can increase the risk load on the kidneys. Of course, the habits like smoking, alcohol, they have to be curtailed. So go out with regular walking, regular exercise, reduce your salt intake, avoid over the counter pills. And if you have a family history of diabetes or high blood pressure, or you are diagnosed with those kind of things at early stages, then go for regular checkup, regular follow. And for those patients who, of course, are more than 50 years, they should, even if they are normal, they should go for this kind of checkups. I think the age old adage that prevention is better than cure will continue forever, because if we can prevent chronic kidney disease at early stage, then there is nothing like it, because the consequences of end stage kidney disease can be dangerous. But if we can prevent chronic kidney disease at an early stage, then we may promise a good quality life and a longevity for patients and their family members as well.
Wonderfully put, very succinctly put, and very aptly put. So, before we end this session, one thing I'm really jealous about you is I was in the thick and thin of COVID. I was ER physician, and my hospital where I used to work, when the government had this, what you call, what was that called? That
Lockdown.
lockdown. So when we had this lockdown, so I was the only guy driving through the streets of Hyderabad in a small car very fast, because there was no traffic. And whenever traffic police used to stop, I used to show him my ID card. He used to let me through. And in my hospital, we had total of three doctors: one a cardiologist, one ICU anesthetist, and in ER, I was the one who was sitting. I've seen a lot of deaths. I've seen a lot of lives I was able to save, but it was a very helpless situation. And in such a helpless situation, whatever I faced, I wanted to put it in writing myself. I wanted to write a book, maybe sometime, my experiences, but you kind of bit into it, huh?
Yeah, just if I
So
can
this
hold the
is
book for a moment.
your book, A Disrupted World.
Yeah.
Maybe I'll write
So
something, An Interrupted World,
no, no, I would
inspired by
appreciate
you. But
that.
tell us more about this book. What was your thinking? What this book contains, and what are all the factors that culminated into making this book a reality?
So, as you just pointed out, that you would have very much loved to write something on COVID 19. So, how I came up with this book, A Disrupted World? during COVID-19, because our lives were disrupted, the entire world was disrupted. And as the book is subtitled, A Mysterious Virus, the virus came from, China, and from the Wuhan province. It was mystery for most of us. And then entire humanity was shattered, and we are in the under the grip of a never-ending pandemic. So we were always asking, can we ever win this war? We of all people, the doctors, the physicians, we are the warriors, as the rest of the humanity was locked down for their safety and the safety of the overall population locked down in their homes. We were there fighting on the front. Maybe we never got that due, like soldiers, and otherwise we still, the society still has to pay doctors its dues, because after throwing a lot of foul petals is not enough. Doctors have to be respected, have to be understood with humility.
I don't
And
think so. Any kind of achievers or some kind of people get Padma Bhushan or Padma Vibhushan or some kind of this one
nothing,
for
nothing,
services. Nothing
nothing,
was done for doctors.
nothing, nothing.
After COVID, the government should
Even
have said that
these,
these doctors have really sacrificed. Who are alive, no problem. But who have really
yes,
given their
yes.
life, they should have been.
Absolutely. I mean, even if you do not honor an individual doctor, the entire medical fraternity can be honored. But in anyway, medical fraternity has never, in want of honors and degrees. We are there on the field, and whenever a crisis grips the nation, we will be there again fighting for humanity. So the book also highlights being doctors in COVID-19 was a very tough thing, because sometimes, many times, you might have seen one day a doctor is taking rounds in an ICU seeing a patient, the next day the same doctor
Is in
might
the
be in one
ICU.
of those ICU beds, and he may never come out of that. And it was such a disturbing experience for most of us, but
And the
even under those things we went.
doctor knows, doctor has seen the deaths, and he has to come back to the home. And
Yes.
if he passes it to his
Yeah, your
elderly
family was
parents,
under
they were sleeping
constant
in
threat.
the car.
Yeah, they were sleeping in the car. Those were images that still remain vivid in our memory, vivid in our eyes. So those things inspired me to put down my thoughts. And of course, I've always been interested in reading books, reading literature, and various kind of books, not just in medical books. Because if I had not been forced to give so much time into medical books, we have read to so many medical books, maybe I would have read other books as well. But I still manage time to read books, and I have started a YouTube channel on review of
Yes.
interesting books, whether medical books for non-medical people, or books starting every aspect of geopolitics. So COVID was one such geopolitical crisis, a humanitarian crisis, which inspired me. And I do have a lot of thoughts, a lot of ideas. If I have time, maybe I'll come up with a full book once again.
Yeah,
You
yeah.
wish me
Looking
good
forward to
luck.
it. And I'll read this book, and I
Yeah,
think
definitely.
this
I
is
would
a very
appreciate if
important
you
book that
definitely.
everybody should read, especially our doctors community. Once I read, I will put up a kind of treatise summarize in my social media handles. So that was a great session, sir. And I think we have done 7, 8 podcasts, and today was one of the best thing. And I have learned a lot from you. Thank you very much for coming and doing this podcast with us, sir.
Thank you. Thank you very much for giving me this unique opportunity. It was also a special opportunity for me. Thank you once again. My best wishes.
Thank you, sir.